Hello, I'm Paul DeMusto from the University of Wisconsin, and today I'll be presenting a microlearning for the SVS on medical optimization in uncomplicated acute type B aortic dissection. I don't have any disclosures related to this talk. So there are several guidelines out there about the management of type B dissections, including the recent SVS STS reporting standards, the ACA AHA guidelines, the STS AATS guidelines, and there will be forthcoming guidelines on the management of dissections from the SVS as a writing group has been formed. However, I wanted to focus in on the specific medical management and how to optimize this for a patient with an uncomplicated dissection. We all know that there are several clinical risk factors or exam findings that would make us suspect a dissection, including a patient with a connective tissue disease such as Marfan syndrome, someone with sudden onset of chest, back, or abdominal pain, particularly a tearing description of the pain, or an unequal blood pressure, focal neurologic deficit, or signs of malperfusion. When these clinical diagnostic signs are present, we often move to imaging, with CT angiogram being the main modality used for diagnosing acute aortic dissection. These are widely available. It allows quick imaging as well as operative planning if necessary. MRA can be an alternative if the patient cannot get a CT scan for some reason. Now, there are several ways that we classify dissections, including the chronicity of them, the anatomy, and complicated versus uncomplicated. Just to briefly review these, the chronicity is defined from hyperacute to chronic, with hyperacute being less than 24 hours from symptom onset, acute 1 to 14 days from symptom onset, subacute 15 to 90 days, and chronic something that's more than 90 days from the beginning of symptoms. Now, traditionally, we classified the anatomy of a dissection based on either the DeBakey or Stanford classifications. However, in 2020, the SVS came out with updated guidelines that allow us to have more precise definitions of where the entry tear is and the extent of aorta involved. The reference to this publication is here at the bottom of the slide. In these guidelines, there's also a nice definition of what is uncomplicated versus complicated. Basically, uncomplicated is someone who does not have rupture, who does not have malperfusion, and does not have any of the high-risk features listed on this slide. These include refractory pain or hypertension, bloody pleural effusion, an aortic diameter more than 4 centimeters on initial presentation, radiographic signs of malperfusion, readmission after initially being managed medically, an entry tear on the lesser curve, or an initial false lumen diameter more than 22 millimeters. Patients that are obviously complicated are those that are ruptured or have malperfusion upon presentation. The recent AHA guidelines tell us that we should manage patients with uncomplicated acute type B dissection with medical therapy as the initial management strategy. Those that have complications or rupture should be managed surgically. When we get into the medical management of patients with type B dissection, intensive care unit admission for arterial line, monitoring of the blood pressure, and titration of vasoactive drips is required. The target should be a systolic blood pressure less than 120 millimeters of mercury and a heart rate between 60 and 80 beats per minute. This is typically done initially with a beta blockade to reduce impulse. And in those that have contraindications to beta blockade or need a second agent, calcium channel blockers can be used. Vasodilators are used later in therapy once beta blockade or calcium channel blockade is in place to prevent reflex tachycardia. Pain control is also important. In the long term, these patients need to maintain this blood pressure and heart rate control, typically with beta blockers as a first-line agent, and then additional antihypertensive is needed, particularly ACE or ARBs. There are several different IV beta blockers available. However, the most common one that's probably used is esmolol. This has a very quick onset and short half-life and can be titrated and adjusted rather quickly. However, the downsides to this are that it can lead to a large volume of infusion, which can lead to eventual volume overload in the patient, and this can be rather expensive. Labetalol is another choice that has alpha, beta 1, and beta 2 antagonists with much more beta blockade than alpha blockade. This has a relatively quick onset, but a much longer half-life. When we usually give labetalol, we're giving it in bolus dosing. However, in the infusion setting, it can also be used and work well in dissections. This can lead to a, excuse me, lower costs and lower overall infusion volume. Just like with any beta blockers, in patients with severe asthma or COPD, these may be contraindicated. However, those patients are fairly few and far between. When we look at IV vasodilators, nitroprusside is one that comes to mind, which causes both arterial and venous dilation via nitric oxide. This has, again, a quick onset and short half-life and can be titrated relatively quickly. It can lead to unpredictable effects, particularly in patients with diastolic dysfunction, can lead to reflex tachycardia, which is why we need beta blockade in place in our dissection patients before starting this, and with high doses can lead to toxic metabolites. Nitroglycerin is another choice, although this has more effect on the venous system than the arterial system. Again, this is fairly universally available, can be quickly titrated and adjusted, and again has similar side effects or limitations. IV calcium channel blockers, nicardipine is the tried and true that's been around for a long time. Again, it can have a quick onset, but can have a relatively long half-life. This can be titrated, but much less quickly than some of the other medications. However, this can work fairly well. Clofidipine is a newer IV calcium channel blocker that has a very short half-life and can be titrated on the order of minutes. However, this is, again, very expensive and can lead to volume issues. Also, with it being a newer drug, it is less well studied. In terms of oral medications, carvedilol is the standard when it comes to beta blockade, as it has both beta 1 and 2 antagonism and also some alpha antagonistic properties. This, again, just like any beta blocker, can be limited in patients with severe asthma or COPD, and this is a BID drug that has a wide therapeutic range. Amlodipine is a calcium channel blocker that we use most frequently. This causes peripheral vasodilation and is a daily dose. The one limitation of this can be some patients developing peripheral edema. Lisinopril is the most common ACE inhibitor that we use. This, again, prevents the formation of angiotensin II, and this is an excellent long-term agent for these patients to be on. A few patients will develop cough or angioedema, and hyperkalemia can develop, especially if there is renal insufficiency at baseline. And then hydrochlorothiazide, again, another widely available and inexpensive drug, is a diuretic that can help reduce patients' blood pressure with some possibility of electrolyte imbalances related to its administration. Here at UW, we developed a very specific protocol to standardize the management of these patients with uncomplicated acute type B dissections. This was done partly to standardize care, but also to try and reduce costs related to drugs and ICU length of stay, and to reduce overall hospital stay, obviously without harming patients. This protocol was made using input from pharmacy, cardiology, critical care, anesthesiology, vascular surgery, and emphasizes the early initiation of oral medications. We try to wean the antihypertensive infusions as quickly as possible once oral medications are on board, and we have frequent assessment for de-escalation of care. Any patients that have suspected acute aortic dissection are initially put on this protocol after undergoing CTA imaging to confirm the diagnosis. Patients get a basic set of labs. A TSH is important to make sure there's no other driver of their hypertension. And then if a patient has an acute type B aortic dissection, again, less than 14 days from symptom onset, has a blood pressure that requires antihypertensive infusions, and there's no signs of a complicated dissection, we then place them on this pathway. We follow the AHA guidelines for a goal systolic blood pressure of less than 120 millimeters of mercury, heart rate of less than 80. We use labetalol as our first line infusion, which has helped us decrease our pharmacy costs and our issues of volume overload. We then add nicardipine, and nitroglycerin as our third line infusion. We work with the pharmacy to concentrate the drips if patients are on them for more than 24 hours to reduce the volume that they get. And if patients have been transferred out of the ICU and are doing well, but then have a spike in their blood pressure, we use nicardipine and nitroglycerin in those cases, as this can be given on the moderate care floor and avoid a return to the ICU. Again, all these patients are already on oral beta blockade. In terms of our oral antihypertensives, we start with amlodipine 5 milligrams a day and carvedilol 12.5 milligrams twice a day. We actually evaluate the patients and will increase the the carvedilol twice in the same day up to a maximum dose, or when we're limited by heart rate. We evaluate by day 2 and increase the amlodipine if needed. And if we're still not achieving control and requiring drips, we'll add lisinopril and hydrochlorothiazide, with the caveat that before adding lisinopril, we want to make sure that we're fairly confident the patient's not going to need an operative intervention. We then increase the lisinopril daily and the hydrochlorothiazide daily until we achieve our goals. If we're still struggling with all of this, we consult our cardiology colleagues to help us with additional medications and titrations. We also make sure that we have adequate pain control, which is something else mentioned in the guidelines. All these patients get an inpatient cardiac rehab evaluation. We're sure to monitor their blood pressure during physical therapy and get them a home blood pressure cuff that they know how to use to follow their blood pressure. If needed, we get them an outpatient cardiology referral, and patients with atherosclerotic disease are initiated on statins and medical management for that. This table shows a nice summary of what I've just described, starting with our ICU admission and starting with our infusions and initiating PO therapy at the same time, and then titrating our oral medications as we work towards discharge for the patient. We did review this in our experience here at University of Wisconsin in a total of 39 patients, roughly equally split between our pre-protocol and post-protocol groups. I should note that we did not have any differences in demographics or the baseline characteristics of the patients. We were able to reduce the length of stay overall, as well as in the ICU, between the pre and post protocol groups. As you can see, our overall length of stay went down by more than 3 days, and the ICU length of stay went down by about a day. With focus on titrating medications to their max dose before adding another medication, we were also able to reduce the number of oral blood pressure medications the patients are on at discharge by roughly 1 medication, and we did not see any change in our 30-day mortality. We also were able to reduce our costs of the total cost of the hospitalization, the variable cost, the pharmacy cost, as well as the variable inpatient care cost for these patients. So overall, having a goal-directed protocol for medical management can help reduce resource utilization and costs without compromising outcomes for acute uncomplicated type B aortic dissection. We were able to reduce the number of blood pressure medications at discharge and the length of the hospital stay without any change in 30-day mortality. And we are now using this and looking at this in other aortic syndromes. Thank you, and please feel free to reach out if there are any questions.